Today I want to discuss something that is critical: testosterone safety in men with prostate cancer. This slide introduces the complex relationship between testosterone and prostate cancer. It highlights that both prostate cancer and low T become more prevalent with age. Despite extensive research, this topic remains controversial among physicians and surgeons. The controversy surrounding testosterone and prostate cancer, stemming from Charles Huggins' Nobel Prize-winning study in the 1940s. His work on ADT for metastatic PCA showed cancer remission and led to the dogma that testosterone is vital for prostate cancer cultivation. That despite a more nuanced understanding of testosterone's role in prostate tumorigenesis since Higgins' era, the FDA requires testosterone products to display a warning about the increased risk of prostate cancer and contraindication in men with breast or prostate cancer. For me, it is important, and I want you to know, the impact of low testosterone, including physical, sexual, psychocognitive, and metabolic effects, leading to a reduction in overall health and quality of life. It also notes increased rates of bone mineral density loss, glycemic control issues, and major adverse cardiovascular events. This slide outlines the effects of low T on sexual function, such as lower libido, decreased sexual activity, reduced nocturnal erections, increased rates of ED, poorer response to PDE5I, reduced ejaculate volume, and delayed orgasm. Some critical points in our clinical practice include the type and date of treatments performed for prostate cancer, as well as pathology reports that detail the Gleason score, extracapsular invasion, positive margins, lymphadenopathy status, and compromise of the seminal vesicles. PSA trends before starting T therapy are critical. PSA must be stable for men with prostate cancer and active surveillance or prostate cancer after radiation therapy with or without androgen deprivation therapy or after focal therapy. PSA must be undetectable after radical prostatectomy before T therapy as well. For men on T therapy, we evaluate all PSA labs since treatment to assess trends. The PSA must remain undetectable after radical prostatectomy or remain stable after radiation therapy or focal therapy. For men on active surveillance, following the protocol based on PSA, MRI, and biopsy is critical. For men with profoundly low T, PSA must be followed frequently. We follow up the PSA every 3 months during the first year on T therapy. Finally, to have direct communication with the oncology team is critical to improve outcomes and safety. The AUA Guidelines 2018 regarding testosterone therapy in men with a history of prostate cancer, emphasizing the need for shared decision-making. It outlines considerations for post-radical prostatectomy, post-radiation therapy, and active surveillance cases, noting the limited data and concerns about potential progression of prostate cancer. Recently, I published this data in which I evaluated the relationship of PSA and testosterone in men with prostate cancer. We observed that the prevalence of low testosterone was significantly higher in men with worse Gleason grade groups, particularly those in Gleason grade groups 4 and 5. The prevalence of low T was also much higher for men with Gleason grade groups 4 and 5 and lower PSA. The Traverse study is one of the most critical and recent studies that showed no association between T therapy and the development of any prostate cancer or high-grade prostate cancer when a cohort of men on T therapy was compared to men without T therapy. Based on retrospective studies, low T appears to be highly prevalent among men with newly diagnosed prostate cancer. A retrospective study in a cohort of 681 biopsied men observed that 31% of men with prostate cancer had low T. Looking specifically at men with low-risk prostate cancer for whom active surveillance would be recommended today, one study showed that 16% had low T. In men with prostate cancer who are on active surveillance and have low testosterone, most studies have shown no significant changes in PSA levels, no increase in disease progression, and no difference in proceeding with definitive treatment when comparing men receiving testosterone therapy to those not receiving it. In men with low-risk prostate cancer, specifically those with a Gleason grade group of 1 to 3 and organ-confined pathology, which means no involvement of lymph nodes, seminal vesicles, or surgical margins, no significant difference in biochemical or prostate cancer recurrence was found between those who received testosterone therapy and those who did not. This finding was observed after radical prostatectomy and during a follow-up period of up to 5 years. I recently published a study comparing low-risk prostate cancer patients with low testosterone levels who were on testosterone therapy to men without testosterone therapy after undergoing radical prostatectomy. Follow-up was conducted for up to 10 years, and the findings revealed no differences in prostate cancer recurrence between the two groups. Patients with high-risk prostate cancer, specifically those with high-grade disease and positive lymph nodes, surgical margins, or seminal vesicle invasion, face a significant risk of recurrence due to their baseline pathology. Currently, there is no data on the safety of testosterone therapy for this particular population. Therefore, a thorough and informed discussion is necessary to assess the appropriateness of testosterone therapy in these cases. What about T therapy in men after radiation therapy? You need to know that the prevalence of low T in men with prostate cancer treated with radiation therapy, with or without androgen deprivation therapy, varies between 22% and 59%. Several studies have demonstrated that despite the protocol's intention to provide only a temporary castration effect, T recovery after ADT cessation may be only partial and take prolonged periods of time. In my practice, I usually recommend T therapy after 2 years post-radiation therapy. And again, most of the data published on this topic, T therapy for this group of patients has shown no difference in prostate cancer recurrence. Balancing the risks and benefits of testosterone therapy is crucial. A well-informed discussion with the patient is essential. In summary, patients with a history of prostate cancer need a complete evaluation and require an extensive discussion about the risks and benefits. Despite years of research and published evidence, the topic remains a controversial one for physicians and surgeons. Most of the evidence has shown that T therapy is not associated with prostate cancer development, progression of disease in men with prostate cancer, and active surveillance or prostate cancer recurrence in men after active treatment. T therapy is safe for men with prostate cancer. It is important to identify the right patient who will benefit safely from prostate cancer treatment. That's it for today. Check out the rest of the videos on sexual health topics in my channel that I created to help you get better sexual education and improve your sex life. Please give me a like, share it, and subscribe. See you in my next video.